I'll tell you as we go why we use the word tender conversation. But I think we have these kinds of conversations at home. We have them when somebody calls us to tell us something has happened. Of course, COVID has left quite a legacy for all of us of having gone through very difficult times. And it's so good to be back at CMC. I'm very happy to be here, see old friends and meet new friends and colleagues, because at the heart of this institution is compassionate care and of service. But of course, unless we care for ourselves, we can't care. Discussion. Jutta and I are very used to working together. We're happy to take it like that. We also, I think, might ask for some role play. So if you're really keen, there's going to be a chance to volunteer. During COVID, I became part of a Northumberland Celtic monastery tradition. It was a cycle of prayer. It started when people were in lockdown. I was in Uganda at some point, in Gaza at some points. There was a group of us who've met now for more than 2.5 years. And some of the meditations and verses and prayers have been very meaningful to me, and I'm going to share 2 in my talk this morning. John Philip Newell is a theologian exploring spirituality in his theological studies. But I love this meditation. Let me just read it to you. At the heart of this meditation is, how do we see someone else? Or how do we see the world around us? Whichever way we turn, O God, there is your face, in the light of the moon and patterns of stars, in sacred mountain rifts and ancient groves, in mighty seas and creatures of the deep. Whichever way we turn, O God, there is your face, in the light of eyes we love, in the salt of tears we have tasted, in weathered countenances east and west, in the soft skin glow of the child everywhere. Whichever way we turn, O God, there is your face among us. And our chaplain has already prayed, hasn't he, and recognized that it is actually because of Jesus, it's because of that knowledge that we are made in the image of God, that we can then see someone else as absolute. How does that translate into our healthcare? We've thought about that already. Palliative care has lots of ways of defining it. This is a simple way, which I find helpful. It's a relief of suffering. And of course, that involves all aspects, the physical aspects, the psychological and the social, and of course, the spiritual. It's about improving quality of life. This phrase comes from Nairobi, adding life to days, not just days to life, and dignity. And I'm going to bring you stories from different places I've worked, particularly Uganda. That image on the first slide was a South Sudanese lady that I met in the refugee camps. I'm privileged to do work with a network looking at humanitarian settings and chronic illness and palliative care. But let me introduce you to Rose, just to set the scene for what we're talking about today. She was HIV positive and had been a patient advocate. So she had done a lot of community work to try and address the stigma of HIV/AIDS. And then she developed cancer of the cervix. Many of you will know that that's an associated cancer. And she said, okay, now I want to be an advocate for this. And in fact, the picture came and spoke to 300 people at our national conference. She gave permission for these photos, and she talked about what palliative care had meant for her. And I think it's very profound. It's difficult to read. Let me read it for you. You gave me hope. You gave me pain control. You gave me love. And then she turned to the Ministry of Health representative. She said, make sure everyone in Uganda has his care. She was still being an advocate. But I think that's an interesting and beautiful synopsis, isn't it? Hope, pain control, and love. Tender conversations, those are the conversations that are difficult, that we've got to be sensitive. Our natural inclination can be to avoid them, to run away from them, or to feel so uncomfortable that just as the director says, we put up barriers. Chitra will talk about that more later. The same is there for our patients. Sometimes their natural inclination is to say to us, don't tell them. It'll just make them upset if you tell them. Have you heard that said? I think so. So when we get into our group work, we're going to think a bit more about that. When someone says that to me, I'm hearing that they're just feeling anxious, worried, maybe a bit frightened, maybe a bit overwhelmed. I'm going to introduce you to a really tough conversation that I had, and this is a pretty tough one, and I want you to think just some of the stages for little Catherine. She has died since this picture, but she gave me permission. In fact, she said, you can take this picture if you use my words to teach people. So Catherine is teaching us today. She's 9 years old. She's Ugandan. She comes from a very humble family. She's in the National Hospital where I work in the capital, 9 hours away from her home. Her mother is sleeping under the bed. This will be familiar to many of you. And there's no earning because her mother is a tailor if she's there. She has an odd respiratory illness. It's been progressive over 3 to 4 years. Now she really has end-stage fibrotic lung disease. They have tried very hard to look for a cause. They've sent biopsies here, scans there, but really now she has end-stage fibrotic lung disease, and she only can be off oxygen for a matter of minutes. She chose this photograph to be the mask off, just a matter of minutes. And when I met her, the team hadn't been referring patients so often from that ward, but they were really struggling to know how to answer her questions. So she's saying to me, her mother is there, her brother is there. I said, it's nice to meet you. My team and I have been asked to come and see you. I gather you have some pain. You're struggling to breathe. What is the... And she says, I'm going to be okay. Yeah. Now, of course, when a child says that, what do we want to say? Don't worry. It's going to be fine. Yeah. And I could see her mother was looking at me as if to say, you have to say that. And her mother said, don't worry, it's going to be fine. So I just said to her, you've asked me quite an important question. Tell me what makes you ask it. She said, well, I've looked around the ward here. I've been here for 10 weeks. Everyone either goes home and gets better or they die. So she asked me the next question. I think I'm going to die. Now that's a tough moment, isn't it? And sometimes when those questions come up, we feel we have to have the right answer. Many, many times we are being asked to hold a really difficult place, to listen and have empathy for the suffering of that family, but also to hear what this little girl is asking me. I don't know how you'd have answered that. I won't ask you. You can maybe think yourself. But I said again, this is a very, very tough question you've asked me. I'm thinking this is a question you've been thinking about. She says, I think about it all the time. Asked anyone else? She said, when I ask them, they say, don't worry. And she says, my mum tells me, don't worry. I am praying to Jesus. Everything will be fine. So I said to her, would it be okay if I talk to your mum and your brother and let's give you something for your breathlessness? She had some pain and breathlessness, and we'll come back tomorrow. And if you still want to ask me that question, perhaps we'll talk a little bit. I spoke to her mother, the brother, a lot of tears. They realized she was dying quite soon. They really didn't want her to worry, but they did agree after some discussion that we could just step by step. But I said to the mother, how has she been with you? And the mother said, she doesn't even talk to me anymore. Yeah. And I think this little girl was tired of her questions not being answered. And so she just stopped talking. She also didn't have much breath. So I went in the next day. We were going to have a conversation, but she said I had a very bad night. What happened? And this is what she asked me. You know what she said? She said, my mum told me that Jesus was going to rescue me, but I'm not getting better, so I think Satan must be winning. So can you see that in an effort to reassure her, in an effort to protect her, in an effort to have her not worry, actually her worries were far, far, far more. And over the next few days, for Catherine. Her family talked with her. We talked with her. We did address the symptoms. She asked for her hair to be done. I asked if I could tell her story. She said, only if I have a nice picture. She had ice cream. She had her favourite Bible stories. We bought a radio. So in the night, if she woke and she was frightened, there was a Christian music channel there in Uganda. She could listen to that channel. So we were looking at spiritual and psychological and physical and social support from all angles. And what she said to me, she said, do you know, I'm not frightened anymore. I just tell that story, one, so that Catherine can still teach us. Also for us to realize that even the toughest conversation, if we can gently together find a way through, if we can acknowledge, I acknowledge with her that her body had actually run out of the ability to keep the oxygen coming through her body. That's why she needed the mask. She wasn't surprised. And that quite soon, even that was not going to be able to happen anymore. She wouldn't even with the oxygen be able to live. And she was very okay about that. So that's a tough one, isn't it? But I think I want to let Catherine teach us something, and that is gently, step by step, holistic. Let us hear our patients when they want to have these conversations. We didn't fight with her mother. We didn't say she's done the wrong thing. The mother was only doing what she thought was best to care for her. But together with the team on the ward and with the family, we were able to just move into a place where everybody was still very sad, but much more at peace. I have a colleague I trained with. She worked for many years. She retired. She wrote a book. She was a palliative care doctor. We were the first batch to train in palliative care in the UK in the early 90s. And she's now become a best-selling author. She said she never imagined that would happen after retirement. She's written 2 books. The first one, With the End in Mind, is really trying to talk about the process of dying, particularly in countries like the UK. She's in the UK, where it happens in a hospital ward or in a hospice, kind of separated. People become more and more frightened. It drives discussions such as euthanasia, for example, fear of loss of control. But then she wrote this one, How to Find the Words for Tender Conversations. And what she said was, I was tired of teaching breaking bad news. Have you heard that term? Breaking bad news. Because that is, giving information is a component of this conversation. But actually, it's quite a precious moment where someone is trusting us with their fears and their worries and their concerns. And we're bringing our skills, our listening in particular, but other skills, Chitra will talk about that, I'll mention some of them, into that space to offer true compassion in that situation, to offer it, I heard, with professional skills and being ethically sound. I heard the chaplain pray for that. Absolutely. So we're going to be talking today, how do we actually go about doing that? And I recommend her book. And she also talks about this being a layered, nuanced thing, just like the first time you put in a cannula. Or we have some nurses here, I think. Wave to me if you're fantastic, brilliant. Sometimes you will have these conversations almost more than the medical staff, because we have the diagnosis conversations, maybe the relapse conversations, but you have the conversation when they're being washed, when they're having their wound dressed, when they're crying on your shoulder. And so we actually, all of us have a really important, this is step by step. It's not one conversation. It's a number of conversations, all of which have this sensitivity and something quite precious about being trusted in that moment. And we are together helping offer care to that person and to their family. And she talks about it being almost like a dance, listening and following the dance. Some of you do things. We were talking to Dr. Bala about bronchoscopies, and some of you, how long did it take you to learn how to do that? Some time. And you had to learn different techniques and different skills. So don't be afraid of training in this area, of being mentored, of watching people who have got this skill, learning from them. If you have a chance to do placements with, for example, palliative care or other colleagues who are good at this, you can learn through mentorship, through training. You can take innate skills and develop them. You can also take innate skills and actually distance, like the director said. In Catherine's book, this is the kind of list she uses. I think some of you are familiar with a tool called spikes. Do you know Spikes, some of you? I see a few nods. There's various tools. She lists this in her book, How Do You Get Started? How do you listen to understand? So really listen because you genuinely want to understand. And she also talks about how we actually have these conversations often in our lives, but we freeze a bit when we're in a clinical setting. How do we show empathy and tenderness? Curiosity, genuinely wanting to understand what is behind what they're saying. Of course, there's skills and questions. Chitra will talk about that. But there's this very powerful thing that we can be alongside presence, one of the most powerful tools we can give to people at a time of suffering. Other skills such as silence and how to end. And I think she just encourages us to trust ourselves. I don't know if you've seen these cartoons. This was a writer who's written a lot of books, a very famous book about the horse, the boy, and the fox. And he wrote quite a few more of these cartoons during the COVID era. And they're very profound, very gentle, very simple, but very profound. And this one is talking about kindness. So just a few general issues about tender conversations. Now, one of those is culture. I have the privilege at the moment of working regularly in Uganda, but also visiting Gaza and in the refugee areas of northern Uganda. And of course, very happy after a long break for COVID to be back in India. And every one of those settings and cultures have some differences in how they approach these things. Vellore, you have people that CMC coming from northeast. Chitra and I, we've taught in Mizoram, very different culture from Tamil Nadu. So I don't think you can even say there is an Indian culture for this. There is a UK culture for this. But there are nuances within cultures. And one of the key differences is this individualistic and collectivist cultures. I think you're familiar with that. So one in which it's very much about autonomy and control and wanting to be in control. For example, my country of Scotland, I'm pretty disturbed to see that the drive for euthanasia is growing, but the people who are asking us to look at that are actually saying this is a way for people to feel more in control and they feel to have more dignity. And that says something about our society, that we think that is a dignified thing to do. And, you know, we haven't to criticize people necessarily who ask for that, because they're asking also from the point of view of wanting to do the best for their patients, even if we feel that actually that is a very dangerous path to go down. And then we have the more collectivistic cultures, where it's much more about making that decision together, respecting if it's a family member who is the decision maker, allowing that decision to happen, having conversations together. You see these. You ever have a conversation one-on-one in your outpatients? I don't think so. There'll be many people around, many people coming in, same in Uganda, same in Gaza. So we need to be respectful of the cultural context, but also not controlled by it. So I will speak out against euthanasia as being a dignified dying in Scotland, even though I understand why people are asking that. But I have to find a way to talk about that in a And Chitra, I think you'll talk a bit more in your session, but it's important to recognize the family. Palliative care talks about care for the family as well as the patient. Don't alienate them. Say we're on the same side. We both want what will be of most benefit for your patient. And also the reassurance that we're going to support the family, because sometimes it's their own worries and fears that are driving them to say, please don't tell what's happening. And if we can do that together, respecting some of those cultural norms, but gently moving forward. Here's two concepts just to show you how these can work out positively. I think you will have heard of Ubuntu, or some of you will, that idea that I am because we are. Some of us might also, if there's a strong faith context, say I am because we are, because God is. But that sense of connectedness, Desmond Tutu, lovely quote, my humanity is caught up and bound up in what is yours. But I had the privilege of visiting Dr. Lamboy Haokip in Manipur, professor of theology was professor of theology in Pune, has moved back to really look in much more depth at what the indigenous India have to say about theology, about wisdom, about life, about death and dying. I'd highly recommend this book, which comes from a series of lectures at a conference. But this is there in a cookie culture about interdependence. Look at this last bit: leading life in tune with the culture, love, care, fairness, justice, connectedness, interdependence, and sharing. So we have some of these cultural norms are very deep, very precious, and actually allow a level of palliative care that is difficult to attain in cultures that have lost these traditional tendencies. We have the ethical principles: autonomy, beneficence. I think you know these ones: non-maleficence, doing no harm, justice. We have to balance these with legal frameworks, and we'll look at that in our role play coming up, and trying to find a balance. And I think you do this most days. Should we start this treatment? Should we stop this treatment? Should we refer to this hospital? Should we, how do we balance the needs of that patient and their wider family? And it can feel very difficult at times. You have an excellent end-of-life care document. I saw it. Thank you to Dr. Jennifer. And it's really a very good document. Of the issues we've talked about, but there have been some changes. This is a document from AIMS in Delhi to try and help the legal framework be a bit safer for us. We have tools to help us. This is a very good website if you want to look at. It's American-based, but it actually is it's applicable to all, and also various tools. This is a simple tool we use developed in Malawi that we use just simply about let me ask and explore before we tell, and finally we ask to clarify. Often we tell first and then we ask. My friend is taking a picture. Then, of course, the spikes ones, you'll be familiar with this. This is a ward round in Gaza with really lovely medical students keen to learn. And you can just see the way that they're listening, I think, from that, even on a ward round, even on a busy ward. So again, if you want to know more about this, we can talk later, but it's really helping us frame how we set the interview up, whether or not we check out the perception. What do you understand about your illness? I said to Catherine, why do you ask me this question? And I actually said to her, what do you understand about what's been happening to your body? She told me my lungs aren't working anymore and they can no longer use the oxygen. So in her own words, she'd actually told me, would you like to know? I want to know what's happening to me. So that is those first stages. And then, of course, we share information, we show empathy, we summarize. And just a couple of slides here, a piece of work done by our spiritual care leader who did his master's in theology. Quotes talking about the value of listening. You are your own most important therapeutic tool. The way in which we listen, the way in which we have these conversations can either further push that person into being isolated, not listened to, frightened, or it can actually put them in a place where they can begin to find hope and meaning. And of course, that's what we want to do. And then the value of presence. This is a very strong quote. Your coming here and spending time with me has strengthened me a lot. My moments of strength come when people are round about us. And I just want to finish just with a couple of examples of people that we've taken through communication skills training. I'm sure you would have your own ones from here. The young girl in Gaza saying, it helps me feel the suffering. That is empathy, isn't it? Feel the suffering and know how to help them. Here's a young internal medicine MMed. We train all the PGs in internal medicine in my unit. And he talks about not avoiding difficult conversations. Be very honest that he used to avoid them. He now doesn't avoid them. And here's again our medical students in Gaza. I asked them what values they saw. One of the students said, I think this is humanity until infinity. And this lady told me, I tell my son, she's the mother of one of the doctors, every day, please remember to treat everybody as if they're your mother. And finally, how do we transform ourselves? We're going to think a bit more about that. I love this equation. Compassion, would you believe, has been talked about much more now. It's there in WHO documents. It's there in indicator documents. There's a very interesting document saying, how do we measure quality? And one of the key indicators of quality is actually compassion. So CMC, that is at the heart of what you do here. And I think it's beginning to have more and more attention, compassion to ourselves, our patients and families, but also to the world in which we live and the planet. And there's this equation that's being talked about. This is a colleague from WHO says that an equation for our time is awareness, seeing the problem. I went to the Ranipat complex. We see this CMC started and where it has come from. And at some point, Dr. Ida Scudder had to see the problem, didn't she? So awareness plus empathy, some way in which we identify with, we feel with, we respond, and then action. And that together is compassion. So that was really just an overview just now. I have one, as Chitra comes up, I have one meditation I'm going to pray just as we finish. And this again is from our monastery tradition. I found this very helpful during COVID. The idea that we don't have to have all the answers. That sometimes what we can do is hold those difficult places, not run away from them, not feel we have to give all the answers, but hold those places and bring hope into situations that are hopelessness. And so I'm just going to read this. I'll read it quietly, and you can just listen or pray, whichever you're more comfortable with. We have to be candles, burning between hope and despair, faith and doubt, life and death, all the opposites. And this is the disquieting place where people must always find us. And if our life means anything, if what we are goes beyond the walls and does some good, it is that somehow, by being here at peace, we can help the world cope, not understand. Thank you very much. And to Chitra.